Hello, welcome to SPMM Revision on Demand. In this podcast, I will discuss the topic of economic analysis. What is meant by economic analysis? Economic analysis refers to the computation of the costs of a healthcare intervention against the benefits that it provides. To undertake economic analysis, researchers require individual patient data on the costs incurred and benefits achieved with various treatment options. For example, you may want to consider the cost implications when prescribing antipsychotics for psychosis. To make a well-informed decision, you need to collect data on both the costs of individual antipsychotic agents and their clinical impact on patients. Economic analysis is not a specific study design. You can undertake an economic analysis when conducting any interventional study as long as you have collected the cost-related data. RCTs are the most preferred study designs for employing economic analysis as they provide outcome data with higher internal validity than other designs. The availability of cost-related data from intervention trials is crucial to set up an economic analysis. How to compute the various costs associated with the disease and its intervention. Firstly, when treating a patient with an illness, those who provide the healthcare service incur a number of expenditures. These direct costs include items such as the cost of hospital infrastructure, cost of medications, equipments used in a hospital, and the salary of healthcare professionals. Being unwell involves personal expenses for the patient too. Generally, these costs are not directly incurred within a healthcare setting but occur elsewhere. Such indirect costs include the loss of salary due to unemployment while being unwell, the cost of arranging for a caretaker, example, child care costs incurred by a sick mother. Certain costs incurred due to a disease state are difficult to measure or quantify in monetary terms. Such felt or abstract costs are called intangible costs. For example, the cost of suffering or disfigurement due to disease, the economic loss due to social stigma experienced by the mentally ill, etc. Another type of cost commonly discussed in exams is opportunity cost. This refers to the cost of wasted opportunities. A benefit that was given up in order to acquire something else is called the opportunity cost. Every choice or action we make has an opportunity cost. In monetary terms, the opportunity cost is the cost of the second best choice. For example, if you're not studying for this exam, you might have worked a few more locum shifts. The profits you gave up by not doing so is one of the several costs incurred when sitting for this exam. Sometimes you will come across a term called willingness to pay. This is defined as the maximum amount of money that a patient or provider is willing to pay to achieve a specified health outcome. It is denoted by the symbol lambda and expressed as pounds or dollars per unit of improvement. Willingness to pay is an indicator of the perceived value of health state under consideration. It does not reflect the actual costs incurred by an illness. Therefore, it is a proxy economic measure, not an actual cost measure. There is no single ideal value of willingness to pay, but arbitrary reference values are often quoted. For example, the NICE in the UK aims to spend a maximum of £30,000 per QALY of gain within the NHS setting. There are five major types of economic analysis. As indicated in the list here, these are cost minimization analysis, cost effectiveness, cost utility, cost consequences, and cost benefits analysis. We will now consider each of them in detail in the next few slides. Cost minimization analysis attempts to answer a relatively simple question. Which intervention is cheaper? Let us assume there are two interventions, A and B. A costs £1,000 while B costs £3,000. Cost minimization approach considers the cost difference indicated by delta C. In this example, it is £3,000 minus £1,000, that is £2,000. By choosing A instead of B, we can save £2,000 in total. Cost minimization approach is useful only when comparing two interventions that are likely to have the same degree of beneficial effect. But in practice, no two interventions will have the same magnitude of beneficial effect. Therefore, cost minimization is not often useful when making healthcare decisions. Cost effectiveness analysis attempts to answer a critical question: which intervention gives the best value for money? Let us assume there are two interventions A and B. The first step in conducting a cost effectiveness analysis is estimating delta C, the cost difference. The second step is to estimate the difference in effectiveness, delta E, in terms of a predefined outcome measure. This can be any natural clinical unit, for example, a number of relapses, number of days hospitalized, or a clinical scale score, for example, Hamilton Depression Score or Beck's Depression Inventory Score. The difference in effectiveness is indicated by delta E. The extra cost incurred per unit of the extra effect is given by ICER, or incremental cost effectiveness ratio. Mathematically, this is delta C divided by delta E. It is important to note that the acceptability of a given ICER value depends on how much total investment can be made. This is indicated by the willingness to pay. Any decision to use treatment A instead of B has to be based on both the estimated ICER and the willingness to pay. Cost effectiveness analysis is a commonly used economic approach in healthcare settings where a choice has to be made among interventions with different effects for a given health condition. There are some limitations worth bearing in mind when using cost effectiveness approach. Using cost effectiveness, we cannot compare two different health states, example, cancer versus schizophrenia, as the outcome measures or treatment endpoints will be different for these conditions. The units of measurement are clinician or provider focused, for example, symptom change rather than being patient focused. This problem can be addressed by using cost utility approach. We will discuss cost utility approach in a few moments' time. For a given health condition, only one outcome can be considered at a time when you use cost effectiveness analysis. But in practice, a treatment produces many effects, both good and bad. This problem can be addressed by using cost consequences analysis, and we'll see what is cost consequences analysis in a few moments' time. The next in the list of types of economic analysis is cost utility analysis. This answers the question, which treatment gives a better quality of life for the money invested? Cost utility analysis uses the same method as cost effectiveness analysis. The only difference is in the definition of effectiveness. Here, effectiveness is defined in terms of a quality adjusted life year measure, for example, QALY, DALY, etc. These units are called utility units as they reflect the utility or benefit directly experienced by the patient. These are survival benefits adjusted for standard of life. Cost utility approach helps to compare interventions for different health states, as QALY is a universal measure. Utility measures are composite scores that incorporate both the benefits and side effects of a treatment. Thus, they are directly relevant to end users of health services, that is, patients. So this method is considered to be the gold standard for economic analysis. For this reason, cost-utility approach is preferred by institutions such as the NICE in the UK. It is important to note that the value placed by the society for QALYs may differ for various disorders. For example, one QALY gained by treating erectile dysfunction or alcohol abuse may be valued less than one QALY gained by treating stroke or schizophrenia. QALY can change either due to a change in standard of living or survival. QALY is an aggregated index. It is not possible to disentangle the cost of changing quality of life from the cost of changing life expectancy when you use cost-utility analysis. This sometimes can be a problem. This problem can be addressed using cost consequences analysis. This is the final type. This is the fourth type of cost economic analysis. As we saw earlier, the cost effectiveness approach considers the effectiveness across a single dimension. For example, change in HAM-D scores after treating depressed patients with intervention A compared to intervention B. But we know that each intervention results in multiple effects. For example, a treatment for depression can result in number 1, improvement in HAM-D scores. Number 2, reduction in number of days of hospital admission. Number 3, increase in side effects such as weight gain. Number 4, a decrease in number of self-harm events, etc. Presenting the data from these multiple consequences will allow decision makers to weigh up the importance of various treatment effects individually. For example, a change in life quality scores and survival duration can be presented individually in disaggregated format rather than producing a single composite aggregated index such as the QALY. This approach is especially useful for evaluating the cost efficiency of public health interventions. Next comes the cost-benefit analysis. This answers the question, which treatment gives a better return of investment? The method is same as cost-effectiveness analysis, but the difference in effectiveness is estimated in terms of monetary units. This is done by converting clinical scores to pounds and dollars. Both direct and indirect costs are taken into account when you do such computations. When you do a cost-benefit analysis, you present the final result using the difference between delta C and delta E. This difference is called incremental net benefit. So instead of using ICER, in a cost-benefit analysis, you would use INB, incremental net benefit. The advantages of using cost-benefit analysis includes the fact that it helps to compare a broad range of health states and various dimensions of outcomes, because everything gets converted into one single expression, which is in terms of pounds or dollars. Cost-benefit analysis is directly relevant to managers and financial decision makers because both the input and the output are in terms of money. The most important limitation of cost-benefit analysis is that not all health outcomes can be quantified using money. For example, intangible costs such as the cost of pain suffered, the cost of stigma cannot be quantified. So in this case, you cannot have a perfectly measured outcome for cost-benefit analysis. So in summary, this table shows the all 5 methods of economic analysis. You can see that all 5 methods consider investments or inputs in terms of money. Take a look at the outputs and the summary measures. These concepts are often tested in your exam. Now it is time to ask yourself a few questions. Thank you for choosing SPMM course for your revision.